Cold agglutinin disease is an hematologic disease. Look at this picture, shows that signs and symptoms and disease mechanisms. A detail going on. Introduction. Cold agglutinin disease is a rare autoimmune hematolytic anemia in which the immune system mistakenly attacks red blood cells, causing their premature destruction. The disease is characterized by the presence of cold agglutinin antibodies that become active at low temperature, leading to hemolysis, means destruction of RBCs. CAD is often triggered or exacerbated by exposure to cold temperature, infections, or underlying conditions. A definition: cold agglutinin disease is a form of autoimmune hemolytic anemia caused by cold reacting autoantibodies IgM type cold agglutinin that binds to red blood cells at temperatures below normal body temperature, leading to complement mediated hemolysis. Etymology. The term cold agglutinin disease originates from the pathological presence of cold agglutinin, which are antibodies that cause red blood cells to clamp together. Glutamate at low temperature. The word glutatinium comes from the Latin glutenare, meaning to glue together, describing the clumping effect observed in CAD. Types: 1. Primary CAD. Idiopathic CAD. No underlying causes is found. Typically a chronic condition in older adults. 2. Secondary CAD occurs due to an underlying condition such as 1. Infections. Example: mycoplasma, pneumonia, Epstein bar virus. 2. Lymphoproliferative disorders. Example: lymphoma, leukemia. 3. Autoimmune diseases. Example: lupus, rheumatoid arthritis. Causes. The exact cause of primary CAD is unknown, but secondary CAD may result from 1. Infections. 2. Lymphoproliferative disorders. 3. Autoimmune diseases. 4. Certain medications that can trigger an immune response. 5. Genetic predisposition. Risk factors. Factors that increases the risk of developing CAD include 1. Age. More common in older adults, typically more than 60 years. 2. Exposure to cold temperatures. 3. Infections, especially mycoplasma, pneumonia, and Epstein-Barr virus. 4. Lymphoma or other hematological malignancies. 5. Autoimmune diseases. Complications. 1. Severe hemolytic anemia leading to fatigue, pallor, jaundice. 2. Raynaud's phenomenon. Pain and color changes in fingers, toes due to cold exposure. 3. Circulatory problems, risk of blood clot formation. 4. Kidney damage due to hemolysis byproducts. 5. Heart problems, increased workload on the heart due to anemia. Pathophysiology. Cold agglutinin disease is a rare autoimmune hemolytic anemia caused by cold reacting antibodies that leads to the premature destruction of red blood cells. Below is a step-by-step breakdown of the pathophysiology of CAD. 1. Production of cold agglutinin autoantibodies. The immune system produces IgM autoantibodies that targets RBC surface antigens, usually IRI antigen. These antibodies are most commonly monoclonal and are produced by B cell. clonics in primary CAD, idiopathic, or polyclonal in secondary CAD. Example, infections like mycoplasma, pneumonia, Epstein-Barr virus. 2. Cold induced binding of IgM to RBC at lower temperature below 37 degrees Celsius, typically 4 to 30 degrees Celsius. IgM antibodies binds to RBC in color parts of the body. Example, fingers, toe, ears. This leads to glutination, clumping of RBC, making them more vulnerable to destruction. 3. Complete activation, classical pathway. The bound IgM triggers the classical complement pathway by activating C1 protein. This leads to the formation of C3 converters, which cleaves C3 into C3b, depositing on the RBC surface. 4. Clearance of RBCs by the liver, extravascular hemolysis. IgM usually disassociates from RBCs as they return to certain circulation, warmer areas. However, C3b remains bound, marking RBC for destruction. Liver macrophages recognize C3b opsonized RBC and phagocytose them, leading to extravascular hemolysis. 5. Intravascular hemolysis, less common. In some cases, C3b converts into C5, C9. Membrane attack complex MAC, leading to intravascular hemolysis, a direct RBC lysis in circulation. They results in hemoglobinemia and hemoglobinuria. 6. Clinical consequences: hemolytic anemia, fatigue, pallor, dyspnea, jaundice due to increased bilirubin from RBC breakdown, acrocytosis, Raynaud's phenomenon due to RBC glutination in cold exposed extremities, splenomegaly, hepatomegaly, increased RBC clearance, 7. Chronic hemolysis and compensation. The bone marrow increases erythropoiesis to compensate for RBC loss. Reticulocytosis increase in immature RBCs is seen. If compensation fails, chronic anemia develops. Signs and symptoms. General symptoms 1. Fatigue, 2. Weakness, 3. Shortness of breath, 4. Dizziness, 5. Pale skin, hemolytic symptoms 1. Jaundice, yellowing of skin and eyes, 2. Dark colored urine, hemoglobinuria, 3. Splenomegaly, enlarged spleen, cold induced symptoms 1. Raynaud's phenomenon, cold induced fingers, toes, discoloration, 2. Numbness or pain in extremities, 3. Cyanosis, bruise, discoloration of fingers, ears, nose. Diagnosis 1. Complete blood count CBC shows anemia and reticulocytosis, 2. Peripheral blood smear, RBC clumping and polychromasia, 3. Cold agglutinin test detects cold agglutinians, 4. Direct antiglobulin test positive for complements C3D, 5. Serum hepatoglobulin decreased in hemolysis, 6. Lactate dehydrogenase LDH increased in hemolysis, 7. Bilirubin levels increased indicate bilirubin due to RBC destruction, 8. Bone marrow biopsy may be needed if lymphoma is suspected. Nursing diagnosis 1. Impaired gas exchange related to decreased oxygen carrying capacity of blood, 2. Risk for infection related to immunosuppression, 3. Ineffective tissue perfusion related to RBC destruction, 4. Hypothermia risk related to temperature sensitivity, 5. Activity intolerance related to anemia. Medical management treatment goals 1. Reduce hemolysis, 2. Prevent anemia complications, 3. Avoid cold exposure. Pharmacological treatment 1. Rituximab monoclonal antibody first line therapy. 2. Corticosteroids. Example, prednisone, less effective in CAD. 3. Immunosuppressants. Example, cyclophosphamide. 4. Refractory cases. 4. Plasma exchange removes cold glutenins in severe cases. 5. Blood transfusion given with caution and warmed blood to avoid further hemolysis. Nursing management. 1. Monitor for signs of anemia, fatigue, weakness, tachycardia. 2. Prevent cold exposure, warm environment, heated blankets, warm IV fluids. 3. Monitor oxygen saturation and provide supplemental oxygen if needed. 4. Administer prescribed medications. 5. Educate patients about avoiding cold environment and recognizing symptoms. Treatment options. 1. Avoidance of cold exposure, wearing warm clothes, avoiding cold drinks, and maintaining warm living environment. 2. Pharmacotherapy, rituximab, immunosuppressants, corticosteroids. 3. Blood transfusion, only if necessary, using warm blood. 4. Plasma exchange in severe cases. 5. Bone marrow transplant considered in refractory cases. Psychosocial medicine. 1. Patient education, teaching about disease management and symptom recognition. 2. Counseling and emotional support, addressing anxiety and coping mechanisms. 3. Support groups, connecting with others affected by CAD. 4. Occupational adjustments, advising on workplace modifications to avoid cold exposure. 5. Nutritional support, ensuring a diet that supports RBC production, iron, folate, B12. Prevention. 1. Avoid cold exposure. 2. Manage infections promptly to prevent triggering CAD. 3. Routine medical checkups for early detection. 4. Monitor for signs of anemia and seek treatment early. 5. Genetic counseling if there is a family history of autoimmune disorders. In conclusion, cold agglutinin disease is a rare but significant autoimmune disorder causing hemolytic anemia While there is no definitive cure, proper management through pharmacological therapy, lifestyle adjustment, and preventive measures can help improve the quality of life. Early diagnosis and cold avoidance are key to preventing severe complications. Thank you. Have a nice day.